Okay, Rasha, can we start?
Yes, we can. So good evening, everybody, and I would like to welcome you all to our bi-weekly meetings. This is our 12th episode, and it's a very special episode because we are very much honored to have our guest tonight, Dr. Burton Kushner. Thank you for being with us today. We have a variety of very interesting cases that will be presented by our dear colleagues and professors. I'm just going to start off with a very small introduction for a very big doctor. So please allow me. Dr. Burton Kushner, he is with us today. Dr. Kushner graduated from the Northwestern University School of Medicine and completed his internship in Evanston Hospital. His ophthalmology residency
Did not start screen sharing.
Was in the University of Wisconsin Hospital. Oh, sorry. Let me start that again. Okay, so Dr. Burton, Dr. Burton graduated from Northwestern University School of Medicine and completed his internship in Evanston Hospital. His residency was at University of Wisconsin-Madison, and his fellowship in pediatric ophthalmology was at Bascom Palmer Eye Institute. He is the Emeritus Director of Pediatric Ophthalmology and Adult Strabismus Service in the University of Wisconsin-Madison. And among his very well-founding, he's the founding chief and editor at the Journal of APUS, the very famous APUS, where we all try to publish our work. He has also received many awards, the Heat Foundation in 1992 and the Senior Honor Award for the APUS in 1999 and the Alfred Bresler Prize in 2005, and was able to give the talk of the Eugene Falk Lecture in 2005 for the American Academy of Ophthalmology. He has over 200 publications in over his 40 years of expertise in practice. Many of these are on the classifications of intermittent exotropia, amblyopia, diplopia, extraocular muscle overaction, and many more. He has authored over 40 textbook chapters, and these are some of his publications on diplopia, on amblyopia, and atropine in children, and the mechanisms of extraocular muscle overaction. He has also published the book Strabismus Practical Purge. You won't find in textbooks, which is a very important book where most of us use here and all over the world. And also Binocular Vision and Strabismus Grand Round, a collection from the year 1985 to 2002. I will let Dina please introduce our speakers for tonight.
Yes, good evening, everyone. Thank you, Rasha, for this introduction. I'll be co-moderating this episode with my dear colleague, Dr. Rasha Zedan, and we'd like again to welcome Dr. Kushner. And we have Dr. Hala Elhilali, the former head of the Pediatric Ophthalmology Department and Professor of Ophthalmology, Cairo University. We have also Dr. Hatem Saeed, Professor of Ophthalmology, Cairo University, and we're also honored to have Dr. Ahmed Awadein, along with Dr. Ahmed Mostafa Kamal, both professors at our Pediatric Ophthalmology Department, Professor Dr. Rehab Kassem, and as well as Dr. Sara Maher, Lecturer of Ophthalmology, Cairo University. And we'd like to start by Dr. Ahmed Awadein. Yeah, would you please share your screen, Dr. Ahmed?
Okay, so I hope my screen is on. Okay, this patient was a 35-year-old female. She presented with misalignment of her eyes with some drooping of her right eyelid. The condition is dating since childhood, but has been increasing over the past few years. The slit lamp and fundus examination were unremarkable. In particular, there was no abnormal fundus torsion on both sides, and the patient had no history of prior eye muscle surgeries. Now, the patient had a better uncorrected visual acuity on the left side, so the left eye was the eye with the preferred fixation. This was explained by the lower refractive error on the left side. While the best corrected visual acuity was quite similar in both eyes, the patient did not habitually wear spectacles or contact lenses. That's why she preferred fixation with the left eye. So this is how the patient looks when she was fixing with the right eye. You can see that the left eye is exotropic and hypertropic. And when she's fixing with the left eye, she got the drooping of the right eye and drooping of the eyelid. And because the left eye was unable to reach the midline, this was also combined with some right face turn in order to bring the left eye to fixation. Now, examination of the ocular motility revealed when she looks to the right gaze, there is -5 limitation of adduction with some retraction of the globe and what looks like an upshoot of the left eye. And there was a normal abduction of the left eye. There was normal elevation of the left eye in up gazes, up and right, up straight head, and up and to the left. And when she looked down, there was limited depression of the left eye, especially in abduction. Not only that, but you can also notice that when she looks down and out, the left eyelid remains retracted on looking down and out. Now, to make things simpler, this is like a video of the patient to illustrate the movement of the patient. You can see when she looks to the right, you get a narrowing of the palpebral fissure and what looks like an upshoot. And when she looks down, you can notice that there is a limited depression of the left eye and some retraction of the left upper eyelid. In the primary position, the left exotropia measured up to 50 prism diopters with the left hypertropia of 40 prism diopters. Both the exotropia and the left hypertropia decreased or diminished on left gaze, and they increased markedly on right gaze. There was only a very minimal pattern, but you can notice that there was some increase in the hypertropia in down gaze, which could be explained by the limited depression of the left eye. This is like a Duane syndrome. The questions would be, and now the next question, how are you going to address this exotropia using a single lateral rectus recession, a bilateral lateral rectus recession? Would you do a lateral rectus orbital wall fixation, or you might consider adding a left medial rectus resection? Now, and what is the cause of this vertical component? Is it like a leash effect, a superior rectus tightness, or an inferior oblique tightness? And how are you going to address this vertical component? Would you manage it like a straightforward leash effect and do a wide splitting, or you might consider doing a superior rectus recession or inferior oblique weakening, or you might work on the sound eye? Now I will stop my presentation, and then I will go to the moderators and to Dr. Kushner.
Well, first of all, thank you all for inviting me. It's a pleasure to be participating in this meeting. I didn't get the full details of the cases in advance, but you kindly sent me just a summary of what the topics were, and I realized they were going to be challenging. And indeed, we started off with a very challenging case. I think that my gestalt in just looking at the eye movements and at the measurements is that this is some type of aberrant innervation. Whether, I mean, one of the questions is it a Duane syndrome? It's not a classical Duane syndrome, but I think that there's an element of abnormal innervation as you get in Duane's. And of course, Duane's is, you know, there's the most common type, which is the esotropic Duane's and the classic categories. But there are many, over the years, I've seen many one-of-a-kind, unique, anomalous innervation situations, and I think that this is one of them. I think that certainly if the patient is amenable to you operating on both eyes, I don't think you can really get this looking very acceptable if you don't operate on both eyes, because there's clearly abnormalities in both eyes. But what to do would really be driven a lot by what you find at surgery. I mean, I would imagine that there will be significant restriction of the lateral rectus muscle in both eyes. And, you know, the principle is if an eye doesn't move in a given direction, you have to determine, is it due to paresis or is it restriction? And I would anticipate that you're going to be dealing with restrictions. And the corollary of that principle is if there is restriction, you have to release that. So I would assume you're going to need to be weakening both lateral rectus muscles. I also feel that although the hyper of the left eye is in part driven by abnormal innervation, there's probably also restriction of the superior rectus. So without a crystal ball to know what you're going to find at surgery, I would imagine you will find tight lateral rectus muscles bilaterally and a tight superior rectus in the left eye, and maybe inferior rectus in the right eye. And if they are significantly tight, I would address them by recessing them. So I think that the bigger question, though, is do you need something more powerful? Do you need to put the lateral rectus on the periosteum was one of the options, or a Y splitting? I don't see the role for a Y splitting here. I mean, it wouldn't hurt, but I don't think that would add much. I have a feeling that you're going to find enough restriction that you would not have to put the lateral rectus on the periosteum. But if that's not the case, if you go in and there's minimal restriction, then of course you have to alter your plan accordingly, and putting it on the periosteum would certainly be a possibility. So that's how I would approach it with the information that I have, meaning all preoperative and not intraoperative OR findings.
So I just have one question before Dr. Awadein tells us how he managed the case. Do you consider, Dr. Kushner, imaging for those cases of atypical congenital cranial dysinnervation disorders like this?
It's a very good question. I certainly find imaging helpful in certain types of patients. Imaging can help you with two things. I mean, good quality imaging can show you if there's agenesis of the nerves, for example. But that can also show you if there's anomalous positioning of the muscles, or in thyroid, hypertrophy of the muscles or atrophy of the muscles. I absolutely would not quarrel, would not take any issue with getting imaging. It can't hurt. I'm not sure it would alter how I would approach this particular patient that much. So I would say if it's available, if you can do it, the patient's amenable, if cost isn't an issue, you'd probably learn something. But I think it may not be as necessary as I actually think it might be on some of the other patients that are on the list of what we're going to be seeing today. Does that answer your question?
Yes, thank you. So, Dr. Awadein, could you continue this interesting case, please?
So what I did, for seduction test, I found a very tight superior rectus muscle, as Dr. Kushner stated. Obviously, the lateral rectus muscles were tight on both sides, so I had to go and do bilateral lateral rectus recession, 9 millimeters. I was not sure how many millimeters do I need to correct the hypertropia. So I did a left superrectus recession, 9 millimeter on adjustable sutures. And later on during adjustment, I had to adjust it up to 15 millimeter. But still, at the end of surgery, I still had some residual left hypertropia and left exotropia. This is the patient, how she looked like at the end of adjustment. You can see that she has an improvement, but still she has some hypertropia, especially in looking down, and some and small residual left exotropia. But luckily, a few months later, usually when you do a large recession, usually you get an increase in the effect later on. So a few months later, there was an improvement of the hypertropia. So the patient was almost orthotropic in the primary position. You can notice that she has some retraction of the left eyelid because of the large superior rectus recession on the left side. But still, she has some limited depression of the left eye, especially on looking down and out. There was also some improvement of the adduction. The eye can now cross the midline, but not more than that. Dr. Kushner.
I personally would be very happy with that result. I think that's a wonderful result for one operation in a patient that had so much disfigurement from that huge deviation. One question, you said you initially recessed the superior rectus 9 millimeters, and then you adjusted to 15. You mean a 15 millimeter recession from the insertion, or is that 15 from the limbus?
No, from the insertion.
So that's quite far back, very far back.
But still she had an hypertropia. I mean, even though I did a large recession, she still had the large hypertropia.
And was forced suctions normal for the right eye going up? In other words, the inferior rectus not restricted?
It was slightly tighter than the left side, but not as much as like the left superior rectus. But it was a bit tighter than the right side.
Very nice, very nice. Congratulations. Very nice result.
Thank you, Mr. Kushner.
Ahmed, Dr. Kushner, could I'd like to also ask a question about this case.
Yes.
And the possibility if there are accessory muscles, and that these accessory muscles are also misinnervated or disinnervated, just like the superior rectus, so that making the superior rectus recession alone did not solve the problem.
Well, that's, the accessory muscles do occur, not that often. I've certainly seen that. I was asked about imaging, and that imaging would certainly help determine that, and that might be a case for doing imaging. I think I was influenced. The reason I didn't think of that initially is I understand this was not a congenital problem and it was progressively getting worse. Am I remembering that correctly? So that would tend to have me not thinking along the line of accessory muscles. I'm trying to think if I've ever seen accessory muscles that actually were contractile and innervating. I've seen them where they're like just fibrotic bands. They may show up on imaging, or I may just see them at surgery. I don't recall, maybe I overlooked it or didn't see it, but I don't recall anywhere there was actually a muscle contracting, an abnormal accessory muscle contracting. But it would not, anything can happen. It wouldn't surprise me if that could occur.
Thank you, sir.
You did not image this patient, did you?
No, I didn't image.
Do you have any other questions from our panelists? Okay, so we will move on to our next case by Dr. Ahmed Mostafa.
Hello, everyone. Thank you, Rasha. Thank you, Dina. Thank you, Dr. Kushner, for joining us today. It is, of course, to be with us. Now, my screen, you can see my screen, Rasha?
Yes, we can.
Yeah.
Okay. Okay. I will present this case. Wait, please. It is a female, 3 years old, presented with left exotropia 25 prism diopter, with left hypotropia 12 prism diopter, left ptosis. It is a refraction, right eye just cylinder minus 1.5, the left eye +1 cylinder minus 2.75, and already came with left previous ptosis surgery. It is a presentation of the patient in the primary position, but actually the ptosis is very variable. Sometimes it improves like this, but the eye position is the same. It's XT and hypotropia. When I see the 9 position of gaze, as you see, when the patient look up, and especially up.
Wait.
Ahmed?
Yeah, I lost both audio and visual.
Yes, I think we lost connection on Ahmed. Okay, let's give him a few seconds, Keda.
Yeah.
Maybe we can move on to Dr. Hatem's presentation. It seems that something in the connection with Dr. Ahmed might be wrong until he can hear us. Okay. Perfect.
Okay.
When the patient look up and up to the left, as you can see, it's like DVD. And explained for me when the eye look up and under cover of the left ptotic eye, it's like an obstacle of vision, and the DVD become more apparent. But in the primary positions, there is no evident DVD. So I decided to just try to correct the primary position with left lateral rectus incision 9 mm and left inferior rectus incision 4 mm. Just immediately after surgery, the patient in primary position is very good. The position is okay. She is nice and also in the primary position. During the follow-up, it is very satisfactory result for me. Still have some ptosis to the left eye. It is very variable. Okay. But 2 years later, it presented for me with left consecutive ET. Okay. And now the DVD become very apparent in the primary position. And it is a measurement of the patient in the primary position, still have some hypotropia, 6 prism diopter with 12 prism diopter esotropia, and the DVD become apparent in the left gaze and left and up gaze. So now the question, Dr. Kushner, please, how to manage the DVD? And the patient has at the same time the hypotropia. So if we can manage DVD, it would affect the hypotropia, and the management of hypotropia can affect the DVD. The second question is, will the inferior rectus session increase the DVD, or there is no relation or no significant relation? Just I need to hear from Dr. Kushner.
Yeah, so I have a question. Before the surgery, when you showed the pictures of the 9 fields of gaze, you said there was, the DVD was apparent when she looked to the right and up. And I, of course, saw the left eye being higher there. But do we know that was DVD? In other words, if you cover the right eye and the left eye came down, she fixed with that, was there no hypotropia of the other eye? Might that have just been inferior oblique overaction in the left eye, or do we know it was DVD to start with? Does the question make sense? Do you understand that?
Ahmed, are you hearing?
Okay, well, I'll just answer, I'll comment. I have seen a few patients that started prior to surgery, de novo, that had a small hypotropia. And if you covered the eye, the hypo eye, it would go up. So there was a hypo with DVD. Most of the patients that I've seen with that didn't start out that way. They started out as classic DVD, had superior rectus recession. They were slightly overcorrected, had a hypo, but there was still an element of DVD. When it occurs without having had prior surgery. It's kind of hard to understand exactly how that can be. I think and it's a little complicated to explain over Zoom, but I think it's a situation where the patient actually has a bilateral DVD and they have a very strong fixation preference and they fixate with one eye, so you never see that eye going up. But when the DVD kicks in, they manifest a hypo of the other eye. Now, the other situation, it's interesting, I just got an email this morning from a colleague in India asking about coexisting hypotropia and DVD. And in that setting, it can be if there's coexistent oblique dysfunction. So the patient may have DVD, but they have, let's say, superior oblique overaction. So when they're fixing with the non-involved eye, there's an overacting superior oblique that causes a hypo of the other eye. And then if you cover that other eye, it goes up because there's DVD. I don't think that's what we're dealing with here. The only way I have managed these patients, and it's not, and I'm certainly eager to hear if there's any other suggestions people have to make, because it's a treatment that I'm not that fond of, but that is if the hypotropia is part of the cosmetic problem. These aren't patients that are not going to fuse. So if you feel you have to address the hypotropia, recess the inferior rectus for that, and do a very far posterior fixation Faden operation on the superior rectus. Now, I'm not a big fan of Fadens for DVD, but that's one situation where I would do that. And I've found the results acceptable. Not, of course, nothing with DVD is absolutely perfect. Now, your patient has already had the inferior rectus recessed. And excuse me, one of the questions was, can an inferior rectus recession cause or worsen DVD? I don't think it'll cause DVD in a patient that didn't have the underlying sensory underpinnings for having DVD. But if they have DVD, it will definitely make it worse. And I think that, you know, if you recognize that preoperatively, you may want to do something preemptively in the first place, like recess the inferior rectus and posterior fixation on the superior rectus. Now, in your patient, you've already recessed the inferior rectus. I don't see the 6 hypo as a big cosmetic issue. I don't think I would do further inferior rectus surgery. You could, because anything you do on the superior rectus may make that hypo a little bit worse. But I think I would just do posterior fixation on the superior rectus, maybe with a small recession. And similarly, the esotropia, you see the patient in person. I'm just looking at a slide. It doesn't look cosmetically problematic to me. If it were, you could just advance that recessed lateral rectus a small amount and take care of the esotropia if you feel that that is a part of the cosmetic problem. That's what I would say about that patient.
Okay. Okay, I'm just searching for Ahmed Mostafa. I'm not sure he's.
He may not be there.
Dr. Kushner, would you consider doing something like a recession resection, combined recession resection for the superior rectus?
Yeah, you know, that's a good question. The Alan Scott's procedure, where you recess and resect the same muscle. I haven't done that on the superior rectus. Doesn't mean you. I just don't. I have a lot more experience of doing that on the inferior rectus or the medial rectus muscle. One of the hesitations that I have, it'd be interesting to try that. I think, you know, because a very posterior fixation, standard posterior fixation isn't that easy on the superior rectus. Superior oblique gets in the way, and, you know, there are all the problems that you all know about. I think in order to really affect DVD, now we're not talking about doing that to limit adduction. We're not saying we want to decrease how far up the patient can look. We're talking about eliminating DVD. I think the posterior fixation has to be very far posterior. And I would be very hesitant to do like, 8 or 9 millimeters of sect on the muscle. So that would be my hesitation. I think if you would do more standard amounts, 4, 5, 6 millimeters, I don't think you get the effect you need for DVD. But I never tried that. I don't know. You could try it and let me know. I don't. But I think I would do a standard posterior fixation.
Yes. And what about Y splitting of the superior rectus?
Y splitting?
Yes, I think somebody advocated it recently for treatment of DVD.
For DVD?
Yes.
I haven't heard of that. I don't know why that would work any better than just a recession. The Y splitting I think of as for, on Awadeins to stabilize, to prevent it, and the lower arm of the Y keeps it from slipping up and the upper arm keeps it from slipping down. So you stop the up and down sliding. But I don't understand the logic behind it. If you combine it with the recession may help. But has that been published to your knowledge?
I think it was mentioned in an abstract. Dr. Hala, I think you mentioned this previously, Dr. Hala.
Yes, it was discussed a few months back. The International Strabismus Association, they send a monthly case, and they did say that they recessed the superior rectus and combined that with a Y split. I think it was somebody from Latin America that was advocating using that.
And this was on their monthly case discussion.
Yes.
I haven't been. I sometimes do those, but I don't do it regularly. So I did not see that one.
Okay.
Dr. Kushner, have you tried inferior rectus tucking in DVDs?
Have I done what?
Inferior rectus tucking.
Superior rectus
inferior
tucking,
rectus
inferior
tucking.
rectus tucking. No, well, I think that tucking or plicating is technically it's different, but it works the same way as a resection. And I have only infrequently done that. Now I know that Marshall Parks, this is one of the few areas where I just really disagreed with his approach. He used to approach DVD with inferior rectus resections. And it was very interesting to me. Marshall was very charismatic, and his fellows thought he was like God. I mean, everything he did, they did. But very few of them left the fellowship using inferior rectus tightening as their treatment for DVD. Most of them that I've spoken to, he's trained many, many fellows, and I've only spoken to a handful of them. They all said they were not that impressed with the results. It's a very hard thing to report results on because the measurement outcome is such a moving target, so to speak. It's very, it's hard to measure it accurately. The measurements are variable. It varies over time. So there aren't a lot of good studies on results from DVD. I've only used that as a last ditch operation. If I've done superior rectus recessions, I've done the other things that I typically do, and I still needed more. I've done inferior rectus resections. I haven't, plications and tucking is now taking the place of resections. But when I was, I'm retired from doing surgery now. When I was doing surgery, it was before the vogue of not doing resections and doing plications. But I think they really do the same. They have the same effect. So I only did it in cases that I had already done other things that failed. Now, then the other option, of course, for DVD is an inferior oblique anterior transposition. Maybe I should just mention that in a patient like this, I'm not, it's a powerful operation. I'm not a big fan of doing that unilaterally. I think it causes asymmetry of the palpebral fissure, it causes a hypotropia on upgaze. But that's an option for a patient like the one that we just saw, because the anterior transposition only has effect when the patient, when there's innervation for upgaze. So it should not affect the primary position that much. So I think it's a matter of trade-offs. It probably wouldn't worsen the hypotropias, or at least not significantly, but you have all the downsides of the cosmetic aspect of a unilateral inferior oblique anterior transposition. Be an interesting thing to do in a patient. I've never done that in a patient like this, in a patient with hypo and DVD. And that may be something worth trying.
Okay.
But inferior rectus application in this patient, where there's already a hypotropia, that's going to make the hypotropia worse. I would not consider it.
Yes, definitely.
There's consideration for DVD in general, but not for this patient.
Yes.
Can I add one thing again from the International Strabismus Association?
Sure.
During the discussion on DVD, somebody was suggesting that if in down gaze the DVD is not present, and that happens in some cases, what one could do is recess actually the inferior rectus muscle, because then the eye would automatically, there would be less innervation going to the superior rectus in an attempt to bring the eye down. And therefore that could also decrease the DVD. I would like to know also your opinion on that.
I've heard of this. I actually heard of it a number of years ago, and I heard of it in the context, I'm not remembering who told me about it. I'm almost certain it was someone from Latin America.
Yes.
And they talked about doing it bilaterally, for bilateral
Yes.
DVD, do bilateral
Yes.
inferior rectus recessions. It may have been Harley Beekus, but who's from Brasilia, Brazil.
Mm-hmm.
But who it was isn't important. I was surprised about the logic behind it, but the person who talked about it said that he had done, a handful of cases and had good results. So I don't have firsthand experience with it. I don't think I would try it. I'm skeptical about it, but I'm not skeptical based on firsthand experience of seeing bad outcomes from it. It's clever. I mean, it shows someone who's really thinking about the mechanism of strabismus. But anybody here done that? Anybody on the panel?
Again, like yourself, I'm skeptical about it. I personally don't like to mess around with the inferior rectus, especially not recessing it. And, you don't want to mess around with the patient in down gaze, and it's a very important gaze. So again, I would be skeptical about it.
I think talking about DVD, we can spend the rest of the episode talking just about the DVD.
Yes, we can.
Yeah, thank you for this comprehensive comment, Dr. Kushner. I think we'll move to the next case. Dr. Hatem Saeed, would you please share your screen?
First, I want to welcome Dr. Kushner once again. We have the pleasure to have you with us tonight. I'm going to talk about a slightly different topic, which is superior rectus transposition in Duane syndrome type 1 with an unusual scenario. This is the left isotropic case of Duane type 1. She has a left isotropia of 15 present diopters. She had a previous left medial rectus recession 4.5 millimeters for ET. And the force reduction test over the left medial rectus was negative. I did her a left superior rectus transposition. And these are the pre-operative and the first day post-operative photos. And as you can see, she's very much acceptable in the alignment in the primary position. Good adduction and a slightly better abduction of the left eye. 2 weeks post-operatively, she's much better. She's straight in the prime position, and she has an obvious improvement of abduction of her left eye. And I thought this was the end, and with improved head turn as well. So I thought this was the end of the story of this child. No significant limitation of elevation as well. However, 1 month post-operatively, she had a recurrence of her turn, obvious left limited elevation, better abduction with hypertropia in abduction. So I went for surgery to reverse the superior rectus transposition, and I reassessed the left medial rectus 2 more millimeters to compensate for the effect of reversal of SRT on the primary position esotropia. She has a stormy appearance first day after the second surgery. Then 2 weeks post-operatively, I was astonished to face ptosis in the left eye and exotropia in the prime position. The positive data were improved elevation, maintained abduction improvement despite superior rectus reversal, transposition reversal. However, the negative data were ptosis, -4 adduction deficit, and a prior position exotropia. 3 months following the second surgery, a reversal of head turn appeared. This was the head turn before the second surgery, and this was the head turn after the second surgery. There was an improvement in ptosis, improvement in elevation. However, we have a -1, a -4 adduction deficit, a primary position small xt, an A pattern, mild abduction improvement despite superior rectus transposition reversal, and a small hypotropia in abduction. The final outcome 6 months after the second surgery was again reversal of head turn, ptosis improvement, improved elevation, -4 adduction deficit, primary position small xt. The abduction became defective once again, and the A pattern persisted. So my questions yet to be answered. What is the cause of limited left elevation 1 month after the first surgery? 1 month. Recurrence of head turn 1 month after the first surgery. Occurrence of ptosis after the second surgery, and then disappearance of ptosis 1 month after the second surgery. Maintained abduction improvement for 3 months despite superior rectus transposition reversal. Cause of -4 adduction deficit. Would it be a slip medial rectus or too much recession of the medial rectus overall 6.5 millimeter, given the fact that superior rectus transposition was reversed? How would a -4 adduction deficit would be combined with just a very small xt in the prime position? And what is the cause of development of an A pattern? Thank you. And also, I want to know, Dr. Kushner, what are your thoughts about superior rectus transposition as a transposition surgery for Duane syndrome or 6th nerve palsy?
Before I answer, I just want to clarify one thing on the presentation. Be sure I have this correct. Your first operation was just a left medial rectus recession. And then the second one, or was the medial and the superior done at the same time?
No, I'm referring here, the first surgery was the superior rectus transposition.
The first was the superior rectus transposition.
And the second was reversal of superior rectus transposition with a re-recession of the medial rectus.
Okay, so the first, the medial was recessed earlier, initially.
Earlier, yes.
Okay, so the superior rectus transposition was really the second operation.
Yes.
Okay, that confused me. Well,
do you prefer doing a superior rectus transposition in the first place or not?
Do I what?
Do you prefer doing superior rectus transposition as a transposition surgery for abduction deficit?
So, it's not exactly a straightforward answer as to what I prefer. In Duane syndrome, in typical type 1, I'm not talking about the really unusual Duanes like the first one, esotropic Duanes. I'm a big believer in giving parents, if they're intelligent and can make informed decisions, let them give them options and let them weigh trade-offs and make a decision. So what I tell the parent of the type 1 esotropic Duanes is this. If you want to do something that is safe, simple, predictable, and gives a satisfactory outcome, I would do medial rectus recession in the Duane's eye, modest amount, and a very large medial rectus recession in the other eye. But I tell them that very little can go wrong. It's safe, simple, predictable surgery. But in the best of circumstances, that does not give as good motility, as good abduction, as something that is a little more complicated to do surgically, a little more prone to adverse outcomes, inducing hypertropias and so on. But when it works, it'll give a better result than the other. So if you say you want to absolutely minimize the chance of complications and you'll take a less than perfect outcome, bilateral asymmetric medial recessions. If you want to get the best possible outcome, but understanding you're increasing the likelihood that things may have to be readjusted or, you know, reoperated, then I go with the transposition. Now, when I was doing surgery, we always did transpositions of, it was superior and inferior rectus to the lateral. That's what I did for 6 nerve. That's what I did for Duane's. And then the medial, you know, you worry about anterosegment ischemia. I would either give Botox at the same time of surgery to the medial rectus or do a vessel sparing procedure on the medial rectus. It depends on how big the deviation is and how tight it is. I might recess the medial rectus and take just halves of the superior and inferior rectus muscles. There are a lot of different ways, or do vessel sparing, which is technically difficult but doable. So then Earl Crouch, who actually recently passed away, but he came up with this, he presented at APOS. I've never before seen someone have a new procedure where the first time they presented it, they had like 30 or 35 patients. Usually people do something once or twice and they write it up. He had a poster where he did a large number of just the superior rectus transposition with an augmentation suture. And when I looked at that, I said, this is absolutely crazy. There's no reason that should work. You would expect that it would induce verticals. But he was an honest person and his results looked good. And then this was around the time that I retired from doing surgery. So I didn't have personal experience with it, but many of my fellows have done that. And in general, the results are good. So even though intuitively it doesn't make sense, I think it's a viable procedure. And there was a very recent, I think the most recent JPOS had David Hunter and his co-authors had a large series of it, and the results in general are good. So I think if I were operating on a patient now, I would probably do that. Now, in your patient, I think that after the medial rectus was, the first time medial rectus was done, the abduction was good enough that I probably would have just done a large recession of the medial rectus in the other eye. That won't work if there's no innervation to the lateral rectus muscle, no normal innervation to the lateral. But when there's the degree of abduction, if you look at the bottom picture, of course, I don't know when, this is after which operation? Is this after the superior transposition?
This is after Superrectus transposition.
Okay, so I won't comment on the abduction. But I think the superior transposition is certainly an appropriate procedure in this setting. Did you use an augmentation suture?
No, I didn't.
No.
No.
Okay. And yet you got a big limitation, vertical limitation in the eye after. You know, I think that, yeah. Okay.
I left limitation of elevation.
Yeah.
But
Yeah.
this only occurred 1 month after the surgery.
Mm-hmm.
I started to notice it 1 month after the Superrectus transposition.
Yeah. Yeah, I can't explain why. Usually if it's due to, you know, a matter of technique where the muscle's sutured and all that, you get the hyper or hypo on day 1, right after. So for it to come afterwards, that's late, that's a little bit harder to explain. You know, you'd think, I mean, the question is, why don't they all have a limitation of elevation? If you're taking the superior rectus and moving it over laterally, you're decreasing its vertical force vector. But in Duane's, I think that if, you know, I'm less worried about eccentric gazes. If you induce an A pattern or a V pattern or something like that. If you get them straight in primary, if you have a reasonable range of single binocular vision, I know you can't test it in a child this age, but in older patients, and you take care of the head turn, that's a successful result, I think. And I'm less concerned about what happens when they look way up. I mean, we want patients to look good everywhere, but it's just not, it's not necessarily obtainable. I'm trying to remember all of the questions that you had. I think that the ptosis, I mean, repositioning a transposed muscle once it's healed down is, you know, a fairly traumatic kind of procedure. And I'm not surprised that there was edema or just contusion of the levator. And I'm not surprised that there was ptosis just after and that it improved afterwards. Now, the fact that you've maintained...
Yes, despite the reversal of the surgery.
Pardon?
For 3 months.
Your voice was cutting out. I didn't hear you.
I mean, abduction was improved for 3 months despite the reversal of surgery.
Yeah, it's a little perplexing. You've maintained abduction for 3 months, even though you reversed the superior rectus.
Yes.
Well, I think that's because the medial is so far back and it's totally underacting. And you did have some, not a lot, innervation to the lateral rectus at abduction. So you have no antagonist functioning very significantly, so I'm not surprised abduction's improved. I think what you need to do now, I mean, the medial rectus is clearly, it either slipped or I've seen this in some Duanes after fairly large recessions where the medials just seem to lose their power. They atrophy, they behave like a slipped muscle, and you go in and you see the muscle is there, and I'm not sure why. But I think if you want to fix the reversal of the head turn, you have to go back and find the medial rectus and advance it.
And what about the combination of a very small XT with a huge adduction deficit and the development of an A pattern?
A small XT with a huge abduction. Well, I think that there is very slight, you know, Duanes don't necessarily have zero innervation to the abduction, to the lateral rectus on abduction. Many of them, especially ones if they're older and you can do active force generation, you'll feel some contraction of the lateral rectus muscle. They don't have very good abduction for the most part. Let's see, I lost my train of thought where I was going with that. The question you just asked me was,
how can a -4 adduction deficit be combined with
-4,
just a very small?
Well, I think you have minimal but some innervation to the lateral rectus muscle, and you have a non-functioning medial rectus muscle. So the position of rest is somewhat exo, but on attempted abduction, there's minimal increase in innervation to the lateral rectus muscle. So you don't see any further abduction. The other possibility, you know, the position of rest, if you postulate that both the medial and lateral are not working, the position of rest of the eye is in a slightly exotropic position.
Okay.
So if you have two dead unopposed forces, that's where the eye is going to be. It's going to be slightly XT.
Dr. Kushner, could I just, this case is very interesting. I did a series of superior rectus transposition for isotropic Duane patients, and we did get vertical deviations in 2 cases, and there were 10 cases that we performed superior rectus transposition. And although, my question is, the improvement in abduction was on average maybe a minus or a +1. does that really justify the risk of doing a superior rectus transposition and getting a vertical deviation that wasn't present beforehand? You know, yani, is the binocular field, is it gonna really be that much improved, or yani, we're risking a vertical deviation? Because 2 of these patients developed, one got a very significant vertical deviation, and although we reversed the superior rectus transposition for him, he still had a hypertropia. Another question, Bardo, for Dr. Hatem was,
Yes.
do you think the placement of your superior rectus was like, you know, respecting the spiral of the lower? Do you think maybe that it was advanced or recessed, and that's why you got a limitation? Or I don't know, I think I noticed also the hypotropia in some photos. So do you think that it may be a problem?
I don't think so, because I did respect the spiral of Toulouse, and the whole complications just show up after 1 month after the surgery. For a whole month, it was okay, and there wasn't any limitation of elevation. And this is weird.
Yeah, that's hard to explain. I understand your concern about that. I don't have an answer for that. To address your question, I think certainly if majority or even many patients develop hypers after the transposition, I would say it's not worth it. The modest improvements is not worth it. Most of the publications show that to be a fairly infrequent complication. I'm surprised it's infrequent. If you just think of the force vectors, you think it should happen all the time, but the reality is it doesn't. I don't know, and also some patients get a better degree of abduction than the ones that you described. So it may be you just had, you know, a run of a couple of patients in a row that were the outliers. But that's why I say, I think that for most type 1 Duanes, bilateral asymmetric medial rectus recessions will give you a very acceptable outcome. You recess the medial in the Duane's eye just enough to relieve the restriction. 4 millimeters typically is enough. And then you can do like 8 millimeters in the other eye. You're not going to overcorrect them. And you're not going to overcorrect in the other field of gaze because you're dealing with the Duane's lateral. And that causes fixation duress in that direction. And you'll get some abduction, depending on whether there's any normal innervation to the lateral rectus muscle. If there's none, you're not going to get abduction with that. And similarly, I don't think you'll get abduction with a superior transposition if there is no normal innervation going to the lateral rectus muscle.
Can I ask a question, Dr. Kushner? What about doing posterior fixation to the other side on the medial rectus? Or you're just going for a big recession?
Doing what on the other side?
The posterior fixation suture on the other side, on the median?
So I think that's a very viable approach, and I know some people that do that. I personally, and this is just my own bias, I'm not a big fan of posterior fixation in most circumstances. The approach that I take is I do posterior fixation when I have to, and some people do it whenever they can. The reason I don't like it is I think it's variable, but more importantly, whenever I have a choice of a reversible or non-reversible procedure that give approximately similar results, I'll opt for the reversible procedure. Standard posterior fixation, I do not think of as reversible. It's reversible immediately, you know, if you go back a day or two after, you can take it down. But when you go back later, it's extremely variable what you'll find. In many cases, the entire muscle between the original insertion and the posterior fixation suture completely atrophies and scars down and is non-functional. And in other cases, it's still viable muscle that's just secured in the back. So it's a very, in my mind, a very unpredictable situation for going back. However, mechanistically, I mean, if somebody does a lot of posterior fixation, they're happy with their technique, happy with the results, don't mind the things that I just said about being reversible and so on, it's a perfectly appropriate situation, as opposed to doing small recession in the Duane's eye, big recession in the other eye, you do a small recession here, and maybe a small recession with posterior fixation, and not do an 8mm medial. I think it accomplished the same thing. It's just not my preference.
Thank you.
Okay.
Thank
Thank you.
I think we move on to our next presentation, Dr. Hala Elhilali.
Thank you very much. So this is a 47-year-old male who came to my office in December 2020 with history of gradual, painless right proptosis, which occurred in 2017, followed by a right complete ptosis and hypotropia. And despite asking him several times about whether the onset of ptosis and hypotropia were acute or gradual, whether that occurred before or after he underwent biopsy procedure, he was very undecided about these issues. There was also history of substance abuse. And this was a CT scan that was done recently, again in December, which showed a right orbital pseudotumor affecting multiple compartments with diffuse thickening of the extraocular muscles, especially the superior rectus and the lateral rectus, and an intraconal pseudotumor with involvement of posterior retrobulbar fat and a mild thickening of the optic nerve sheath. He brought me the biopsy results, which confirmed that this was an inflammatory pseudotumor. He had a very mild response to steroids, and that is why the biopsy was done. But the patient in 2017 refused other treatment modalities that were offered to him. But the last 3 years, his condition was stationary. There had been no exacerbations. And this was his motility exam. He had a -6 limitation. He had a hypotropia of the right eye, -6 limitation of elevation in primary position. And I measured 53 prism diopters of right hypotropia in primary position, which increased in right gaze, decreased in left gaze, and also decreased in down gaze across the field. And the fundus exam showed 3+ right X cyclotorsion. At the end of the exam, I found myself asking, what was I dealing with here? Was that a myositis that led to inferior rectus contracture and restriction, or was that an affection of the superior division of the third nerve, which was again likely because of the ptosis, and was that caused by the compression of the pseudotumor, or was that an iatrogenic occurrence which happened during the biopsy procedure? Was it possibly an iatrogenic inferior rectus entrapment, but the CT scan did not show any evidence of inferior rectus entrapment? So I didn't know what that was, but I thought I can fix it. I'd like to stop here and ask Dr. Kushner, trying to get into your head here. How would you think? What would you think about the etiology here?
Well, the first thing, I personally did not get involved in the treatment of orbital tumors. So I work with my oculoplastic people. So my first approach would be, what is it? Do we have a definitive diagnosis? And what can be done to treat it, to make it smaller? What, may I ask you, before I'll continue in a minute, but what, you said the patient declined other treatments. What treatments were offered?
They were offered radiotherapy and chemo or an immune suppression, but he didn't up to take these, but his treating physician said that he found that the condition was stable, stationary, and he didn't feel that at this point in time, 4 years later, that he needed them anyway. So,
and I presume that oculoplastics feel nothing is appropriate in the way of just debulking the tumor.
yes, I did send him to oculoplastics, and they didn't think that they didn't want to approach the intraconal pseudotumor.
Okay, sure.
And so it was up to me to now try to deal with the hypotropia that he had in the primary position.
Well, I think that the way I approach this now, as I said earlier, an eye doesn't move in a certain direction. You have to determine if it's restrictive or paretic. And I think if I were to bet, but it's just a hunch, I think you probably have compromise of the third nerve and that this is paretic. But it wouldn't surprise me if you said that it was just totally socked in with forced ductions. But it's an adult. You can do forced ductions in the awake state. You can do active force generation in the awake state. And that should tell you whether you're dealing with restriction or paresis. If you're dealing with restriction, it would be inferior. It would be inferior rectus entrapment or involvement of fibrosis in some way related to the tumor, and you've got to deal with that by recessing the inferior rectus. If it's paretic, I think with this degree, this total absence of the ability to elevate, you'd have to do some kind of a transposition procedure, like a NAP procedure. I'd take the medials and laterals and put them up, and this is big enough, I'd probably use augmentation sutures on both of them. So that's my thinking at this point.
Thank you. So
you're more confident than I am when you say you think you can fix it.
I didn't think I could totally fix it, but I thought I could help him. So
yeah, I'm sure you can.
Okay, I'll show you what I did. So actually I did do a force duction test, but I did that on table for all extraocular muscles. And I found a less than what I had anticipated tightness of right inferior rectus. It was a little bit tight, but it wasn't as tight as I thought it would be. But I did find a superior rectus laxity. And so I thought that the problem was mainly a paretic problem and not a restrictive problem. And I decided to do a partial nap where I transposed half the medial rectus and the lateral rectus to the superior rectus with augmentation sutures. Because I did find some moderate tightness of the inferior rectus, so and that was also going to be part of my plan. So didn't want to do 3 muscles at the same time, especially when this was an inflammatory condition and the blood supply could be was expected to be compromised. So I added an inferior rectus recession, 5 millimeters on adjustable, non-absorbable suture. And that actually I had to put back to 7 millimeters. I did a conj recession over the inferior rectus because I thought that it was tight and that could add to the problem. And I'm showing here the superior rectus muscle, even though it was lax, it was still very vascular. And the other muscles, the medial rectus and the lateral rectus muscles, looked very much like the muscles we deal with when we operate on thyroid eye disease. So there had been an inflammatory process going on there before the time when I did the surgery. And this is the post-op appearance of the patient. Primary position, he had 5 prism diopters. I measured right hypertropia still of 5 prism diopters. He had improvement in elevation of the right eye, still had 20 prism diopters of right hypotropia in upgaze. But my problem was that that reversed to 12 to 14 prism diopters of right hypertropia in downgaze. Luckily, the patient still had his complete ptosis, and he was very happy when he raised the right lid with his hand and he was very happy with the position of the right eye. But unfortunately, the patient underwent ptosis surgery only last week. 2 days later, he was in my office, very unhappy with the hypertropia and downgaze. And so my questions to you now, would you have done anything differently to avoid the hypertropia and downgaze?
So the patient, by unhappy. Is he diplopic? It's certainly not the
Yes.
cosmesis that bothers him.
No.
Yeah.
He does have diplopia in down gaze.
Yeah. Well, I think that you know, I realize this is hard situations, a hard situation. When you have that big a deviation and you have to do that much surgery to get it up in primary, transposition and the inferior rectus, it's fairly predictable that if you're going to get the patient okay in primary, you're going to have an overcorrection in down gaze.
Okay.
So I think that there are only two approaches that you can take to mitigate that, to minimize the downside of that. One is to target getting them ortho somewhat below primary. In other words, you don't want them to have a big chin up posture. Yeah. But if it's not dead straight ahead, they're a little undercorrected straight ahead, but they're okay with a little bit of a chin up, that may minimize how much of a problem you have in down gaze. That's one option. The other, how much of an overcorrection you have in down gaze, because they're not getting as, the reading position isn't as far down from their ortho position.
Yeah, that's what we usually do with the thyroid patients as well.
Yeah,
like that's what we target.
That's exactly the scenario when people do that.
Yeah.
The other thing is to go to the other eye. You could do post. What is the measurement in down gaze now? Is about 12.
12 to 14.
12
between
to
12 and 14 hypertropia and down gaze.
And in primary, is it exactly ortho, or you have a little?
No, there's 5 prism diopters of hypo still, but he fuses that.
Of hypo, yeah. Okay. Well, the only other option right now is to go to the other eye and do something to the inferior rectus. And that would either be a posterior fixation, a small recession with posterior fixation, or the Ellen Scott's recess resect kind of posterior fixation. And I think that, you know, I think you'll have a good outcome with that. I once wrote an article. I never thought I'd get it published because it was a big series, but it was not a homogeneous entity. It was a homogeneous presentation. Mm-hmm. It was diplopia limited to down gaze. How do I approach the patient that comes in, or as a result of surgery, is fine straight ahead, but they have diplopia and down gaze? Mm-hmm. And it was a whole mixed bag. There were overcorrections for vertical surgery. There were just a whole bunch. But in the majority of them, your options are either surgical or optical. The patient wears glasses. They could have separate single vision reading glasses. You could have slab off prism in bifocals. 12 to 14 is a fair amount of prism, but it's doable. But if it's a patient who doesn't need glasses day in and day out, that's not going to be an acceptable solution. Then contralateral inferior rectus surgery, any one of, depending, each one you have to tailor make it, whether you do a recession with a Faden, just a Faden. With this much deviation, you need to do some recession, or Ellen Scott's recess reset. I think you have minimal chance of making things worse, and you would probably help the patient. Is that what you were planning to do?
Yes, that was my plan. I was going to put a Faden or a T fixation suture on the other, the fellow eye. Another question, is there a line or a limit for inferior rectus recession where after that limit, you know that you will have a hypertropia and down gaze if you go past that? Is it 5 millimeters, or is there?
I think it depends on the whole situation, what you're operating for. Okay. Is it a thyroid patient? Is it a post-fracture patient? Is there primary myopathy? How big is the deviation in primary that you're assessing for? How much function there is to the medial? So I think I would answer, I don't think I would think in terms of there's an absolute number. I've done Graves patients where I've done 6-7 millimeters on one medial or one inferior and didn't get an overcorrection in down gaze. It's a combination of the whole clinical picture. But,
and do you usually also transpose the muscles like half a tendon width nasally when you do big recessions? I know you really prefer that, right? For when you do inferior rectus muscles, to avoid an A pattern in down gaze?
Well, that's a very interesting topic that I have moderately strong feelings on. If you, let's take Graves. So the concern, you do bilateral inferior rectus recessions of a large
Yes.
amount, you get an A pattern. So there are people that say, well, I transpose them nasally to prevent the A pattern. That's going to worsen the intorsion.
Mm-hmm.
And there are other people who say, well, I transpose them temporally because I don't want to, worsen the intorsion that they already have. That's going to worsen the A. So whatever direction you transpose, if you're transposing to prevent the A, you're worsening torsion. If you transpose to prevent torsion, you're worsening the A. Now, I've talked to people who say, well, I do this all the time and I don't get into trouble. I think that the reason people don't get into trouble, and I tumbled on this in an interesting way, is if you do it on a hangback, which is the way we do our adjustable suture surgery, your transposition effect is completely lost because you can put the suture and the insertion over here, but the muscle's going to go back and follow its normal course.
Yes.
I had the opportunity, there was an oculoplastic surgeon who did a lot of thyroid surgery early in my practice. He's long retired now. So, and he always would do his inferior rectus recession and transpose them to prevent the A pattern. And I went back, I reoperated, I'm guessing 5 or 6 of his patients, and not one of them did I find the muscle in a transposed position. Because if it's on a hangback, it gravitates back. So I think that's why people don't get in trouble. I have certainly seen patients. I remember getting a call from one of my fellows that he, so are you familiar with the semi-adjustable technique?
Yes.
Where you put the corners in. So he trained under me and I often did that. So he called me, he had a patient with Graves, and he transposed, he did it semi-adjustable and he transposed nasally to present the A. Patient woke up with bilateral encyclo and was diplopic.
Mm-hmm.
And I said, just go back and reverse the transposition. And the patient did fine. So I personally don't do that. If I feel the numbers are big enough of the recession that I did, that I feel I have to do something to prevent an A, then I'll do a posterior tenectomy of the superior obliques, which will preserve the torsional component and minimize the A. But I don't think you can effectively help yourself by transposing. That's my personal bias. People do it and they get good results, and good for them.
Thank you. Thank you very much.
So before moving on to the next case, Dr. Kushner, you would have gone with the half tendon transposition or NAP as the way Dr. Hala did, or you would have done for the full tendon transposition?
Well, the issue was, to me, it's a matter of how tight the inferior rectus was. Did I need to do inferior rectus surgery? And she said it was somewhat tight. So if I felt that, and that's subjective, I mean, what I say is somewhat tight, you may say it's very tight or not tight, it's a subjective call. If I felt that I needed to do something to the inferior rectus, I would do one of two things. I would either do half tendon transfer, just as she did, with augmentation, or I would do full tendon transfer and put Botox in the inferior rectus intraoperatively. Now, that's a very effective thing when you don't want to do a third muscle. The reason I don't love doing that is you don't know where you stand for a while. You inject the Botox, you get a paralytic effect, and they may be overcorrected, and you have to wait 2 months. And, I like to kind of know where I stand right away. Do I have to go back? Did I induce some adverse effect because of my transposition? I can't tell if I've done Botox. But other than that, it's an effective procedure. I think the half tendon transpositions are also very effective. And I I probably would have done that. If I felt the inferior rectus needed recessing, I would do exactly what she did.
Thank you. And thank you, Dr. Hala, for the interesting case. So we move on to our next case. Professor Dr. Rehab, would you please share your screen?
My talk is on paradoxical abnormal head posture. I'm presenting 3 cases with paradoxical abnormal head posture. This is my first case. He presented with a right head tilt and a face turn to the left side. And on straightening the head, there was left hypertropia. And on the Bilchowski head tilt test, there was an increase of the hypertropia on tilt to the right side. That is on tilt to the same side that the patient is already acquiring. And the hypertropia was almost the same as on head tilt to the left as on the first compensatory head posture he had. So the hypertropia of the left eye increased on tilt to the right, and this is the same position the patient was acquiring as a compensatory head posture. On version testing, the patient had limitation of inferior rectus function in the left eye and secondary overaction of the left superior rectus muscle action with secondary superior oblique overaction in the right eye and secondary inferior oblique underaction in the right eye. He also had bilateral DVD more on the left side, and there was no macular torsion on fundus examination. 3-step test was diagnostic of left inferior rectus palsy with left hypertropia that increased on gaze to the left and increased on head tilt to the right. So the question is, why is the Bilchowski head tilt test positive on the same side as the compensatory head posture? The second case is a boy who presented with left sixth nerve palsy with marked limitation of abduction of the left eye. And he also had a +1 left inferior oblique overaction. However, he had a face turn to the right and not a face turn to the left. So why did he have a right face turn despite a left sixth nerve palsy? My third case was a child who had a medulloblastoma with paralysis of the 4th, 5th, 6th, 7th, and 8th cranial nerves on the left side. He had an esotropia of 70 prism diopters with -4 limited abduction of the left eye, diagnostic of a left sixth nerve paralysis. He also had a -1 superior oblique action on the left side with +2 inferior oblique overaction on the left side. And this 3-step test was diagnostic of a left superior oblique palsy. He, however, had a right face turn despite the left sixth nerve palsy. So why did he have a right face turn despite a left sixth nerve palsy? Okay, I'll stop sharing now.
Okay, I think there are different reasons for each of these patients. I'll try and take them one at a time. The first one with DVD. DVD will have a positive Bilchowski test in a direction that classically, they will have it in a direction that's opposite of superior oblique palsy. So in other words, if I have a left hyper and it increases in right gaze, if it's a superior oblique palsy, it'll increase on, a left hyper, it'll increase on left head tilt. DVD will classically increase on tilting the other way. And I had learned this as just that's the way it is. I think I originally heard that from Art Jampolsky, until I became aware that a lot of patients didn't follow those rules. And I did a prospective assessment of DVD patients and what their eyes did on head tilt. And it turned out, you know, I wrote this long enough ago, I'm not sure of the exact numbers. I think it was about 58 or 59% of patients behaved in that classical way. In other words, a left DVD would increase on right head tilt, and conversely, right DVD on left head tilt. And about a third of patients did the opposite. They had a head tilt the same as though it was a superior oblique palsy. A left hyper would increase on left tilt. And about the remaining percent had either equivocal responses, or they increased on tilting both ways, or they didn't increase on head tilt at all. So the head tilt findings you had there were not surprising to me. Now, some patients with DVD will tilt their head to fuse the DVD, and others tilt for other reasons. DVD patients often have a micronystagmus. If you do tracings on them, they all do. If you look closely, they all do. And sometimes the tilting is because it's sort of like a null point for the nystagmus. And some patients just tilt their head for other reasons. So if you want to sort that out, you could just, number one, observe what if a head tilt goes away with an eye covered, and wear a patch for half a day. Even though he's an older kid, he might do it. And if he's tilting because that controls the DVD, his head tilt should go away. Now, if I had two patients after him, so I'm forgetting some of the details. As I recall, he had a left manifest DVD in primary, and his head tilt, he looked straight, and then he went beyond there, and there was a reversal of the hyper. So I think he's tilting just in a direction that exactly neutralizes his asymmetric DVDs. If we're going to see that again, let me see. Okay. So in head straight, there's a left DVD, and when he tilts to the right, it decreases a little, but when he tilts more, it's not the way I remembered it. But I do see he's got in the upper right, his left DVD increases on right tilt, and his right DVD increases on left tilt. So that's the classic pattern for DVD. But I think before I would say this is different than what I said, I'd want to know what he's actually doing on cover tests, not just in the binocular situation where he could fuse. In his slightly preferred head tilt, does he manifest a significant DVD of either eye under cover? I would bet that it's less than in any of the other head positions. So I would think, and to me, this isn't a very bad head tilt, but if you wanted to correct it, and if his DVD is manifest on its own, I think you've got to do large superior rectus recessions, and I would do them somewhat asymmetrically, depending on what the measurement of the manifest DVD is. The other thing is you could possibly consider, there was some element of inferior oblique overaction. You could do bilateral inferior oblique anterior transpositions instead. I'd probably lean toward the superior rectus recessions personally. Now, the second patient, I'm getting them mixed up. Tell me briefly
Could
the
I
second
just have
one.
one question on this case before we move forward?
Yeah, sure.
If he has a head tilt, he's probably trying to fuse, or is he actually trying to separate the images so that both these images are further apart, not close, so that he's actually
The case we
tilting?
just saw. Well,
Yes.
I'm presuming, again, I'm going by the photographs, that his preferred head tilt was that position of tilting slightly to one side where the eyes look straight. Is that correct? Because there are some patients that will.
Right, you still think to the right where the hypotropia became more. So that means
What is his habitual head position? That's what's not stated here. I see his eyes in different head tilts, but I don't know, how does he care when you're not covering him or asking him, how does he hold his head normally?
The first picture with the right head tilt and a face turn to the left side. And I thought this was due to the inferior rectus paralysis in the left eye.
So I'm seeing two pictures on the left. And the one on the far left, his head is slightly tilted to his right and his eyes look straight. Is that his preferred head position?
Yes,
yeah. If that's his preferred head position, he's not tilting to separate the images further. His eyes are straight. There are patients that tilt to separate the images further if they can't bring them together. Now, I forgot the order you gave him. Was the next one the next case the one with the sixth nerve that?
Yeah, he had a sixth nerve paralysis on the left side. He had a face turn to the right.
Yeah. So I think that given the deviation that I'm looking at in this picture, I would assume that if he turned his head the other way, if he turned to the left, he still wouldn't be able to turn far enough to get the images lined up. So you would not expect him to turn in a direction that would just bring the images closer together, because that is the question that you just asked is based on. It's harder to ignore a second image if it's close. So he may, why he's turning at all, I don't know. I think I would think he would keep his head just straight. But I'm not surprised that he's not turning to the left, because he's not going to be able to fuse. I think the deviation's too big. So why he's choosing to turn to the right a little bit, it may be non-ocular. Again, you could put a patch over his left eye for a short time. And if he persists in a head turn like that, you know that it's not driven by anything to do with the oblique image. I'd look very carefully to see if he has nystagmus. Is there any dampening of nystagmus in adduction? Or it could even be orthomuscular. But I'm not surprised that he's not turning to the left. I just think he's not able to fuse, and he's keeping the images further apart.
Well, I thought it was due to maybe superior oblique paralysis that was not obvious, but there was secondary inferior oblique overaction in the left eye. So I thought maybe there was some form of superior oblique paralysis in the left eye as well. And that's why he was acquiring a face turn to the right. And actually, I did him medial rectus recession on the left side and left inferior oblique recession on the left side too. And he had a straight head after that.
His head is straight now.
Yeah, he first had some form of chin depression, and then it got better later on. So I thought maybe it was due to superior oblique palsy on the left side, in addition to the sixth nerve palsy.
Well, I think that in my experience, patients with superior oblique palsy turn and tilt under monocular conditions. So if he's manifesting this large left esotropia, I would not attribute the head turn to, he may have a superior oblique palsy, but that wouldn't be driving his head turn.
Mm-hmm.
That's my personal take on that.
Okay, and now
let's see, case 3, medulloblastoma palsy.
He had a medulloblastoma and he had palsy of 4 to 8 nerves, 4, 5, 6, 7, 8. And he had esotropia, 70 prism diopters, marked limitation of abduction. And I also thought he had a superior oblique palsy and inferior oblique overaction on the left side. And I still attributed the face turn to the right to this superior oblique palsy.
So, you know, a lot of options we talked about. I think that you'd need to do a transposition procedure for the sixth nerve. And we talked about options for that, the full, the inferior and superior versus just doing the superior rectus and possibly do something to the medial. How long has he had the deviation? No, it's a young child.
He presented at the age of 4, and as far as I remember, he had, well, let me see, just a second. He had his medulloblastoma
Months, years?
At the age of 2 years, so it was
2 years. So he
yeah.
probably has some medial rectus tightness. And I think that I would either do the superior rectus transposition with augmentation and recess the medial, or do a superior and inferior rectus transposition. And if the medial is tight, which it probably will be, either put Botox in it or do half tendons on the vertical transposition and recess the medial. And then the superior oblique palsy, I'd probably do the inferior oblique.
Well, actually, I did a bit different thing. I did a recess muscular plication procedure, and I did an inferior oblique recession on the left side. And post-operatively, he had sort of a reversal of the head tilt. He had pre-op right head tilt, now he had the left head tilt, but the face turn still persisted to be on the right side. And he had a residual esotropia and still marked limitation of abduction. 3-step test was showing hypotropia on right tilt. So why did he have this new head posture? Why did he initially have a right tilt and now he has a left tilt? After inferior oblique recession and medial rectus recession and lateral rectus muscular plication.
I cannot explain that because the surgery was all done in the left eye. He's not fixing with the left eye, and there's nothing there that should drive a head tilt. Head tilts are driven by two reasons: to dampen nystagmus or to promote fusion. And he's not fusing any better with the head tilt or not. And the surgery was done in a non-fixing eye. So I can't explain that. I'm not surprised there's that much undercorrection with the esotropia because I think that the deviation was big enough and the abduction limited enough that a transposition procedure is really needed in a situation like that. I wouldn't think a resect or recess plication would correct it. Now, of course, you know, you're left with you've done two rectus muscles, and so you're going to have to wait a bit. But I think that your next step would be a transposition. And I always worry about anterior segment ischemia. I've never had a bad case of it, but it's something, you know, you have to pay attention to. I think you could do transpositions of, you know, split the superior and inferior and transpose those, or just do the superior and split it. The other option, I believe it's called the Nishida procedure. Are people familiar with that? Where you basically leave the muscles, the superior and inferior, at the insertion. You just put a suture in the muscle belly, and without disinserting it, just drag that suture over toward the lateral rectus muscle. And you should be able to maintain anterior segment circulation that way. I have never done that procedure, but I'm familiar with it, and I know people who do it and like it. Have any of you done that? I saw someone nod their head yes when I mentioned that. So,
yes, it is.
What's your experience with it, Ahmed?
It works fine for me. I did it 2 times before, and it worked very well for me.
Okay.
Actually, the magnitude of abduction that I achieved in the patients was even a bit more than what I got with the standard Hamilshine.
Interesting. Dina, you sort of nodded when I mentioned it. Did you have you done it?
Sorry? The
Dr. Hossam, Dina? I don't, may not be pronouncing it.
I just met Dr. Nishida himself in the APUS 3 years ago when he was introducing this technique. This is why I'm familiar with, but I haven't tried it.
Okay.
I have tried it once and it worked very well with me. Much better even than Janssen operation.
Okay. Okay.
So let's move to the last case. Dr. Sara Maher.
We need to ask Dr. Kushner first. Do you have time for the last case, Dr. Kushner, or are we keeping you?
Oh, no, I have time. If you have time, it's late for you. It's just getting ready for my afternoon activities.
Okay.
Good evening, dear professors. Good evening, Dr. Kushner. Very sorry to keep you late till now, but it is a short case.
Okay.
My case is about a 55-year-old male with history of hyperthyroidism. He performed a thyroidectomy 2 years ago. He has been controlled since then. He did bilateral cataract surgery 5 years ago. He's bilaterally pseudophakic. He presented complaining of bothersome deviation of the right eye. There is no subjective diplopia. The patient has a best corrected visual acuity of 0.3 in the right eye, 0.7 in the left eye. He's pseudophakic with a posterior chamber IOL in both eyes. He has normal intraocular pressure on Simulol eye drops. His pupils are round, regular, and reactive, and he has bilateral myopic fundus with stellate disc. And this is the photos of the patient. He has a right ET of about 40 prism diopters that increases in the right gaze to 75 prism diopters, and to the left gaze it decreases to 30 prism diopters with no specific pattern. Regarding the divergence, he has a -4 limitation of abduction of the right eye with a -1 limitation in the left eye. This is his CT scans showing thickening and enlargement of the extraocular muscles with tendon sparing, typical of thyroid eye disease. So the decision was to perform forced adduction test. He has bilaterally tight medial recti on both sides. So we performed bimedial recession, 6.5 millimeters with conjunctival recession. But the surprise that post-operatively the patient is almost the same. He has almost the same amount of EZO deviation. It's about 35 prism diopters after performing bimedial recession of 6.5 millimeters with the same degree of limitation of abduction of the right eye. And this was his post-operative photos. So I started to think, could it be something else? Being a myopic fundus, I performed an A scan and I found posterior staphyloma of the right eye with an exit length of 31 millimeters of the right eye and 25 millimeters of the left eye. So back to his CT scan, I started to revise it one more time to check for any evidence of heavy eye syndrome. I am asking Dr. Kushner, what are the steps for diagnosing heavy eye in the presence of thickened enlarged muscles? Do we need special cuts in the MRI, or when suspecting heavy eye, how to confirm that or how to proceed?
Yeah, it's very interesting. I don't know that I've ever been faced with the issue of heavy eye, or is it heavy eye, in a patient with thyroid eye disease. And that can certainly make the interpretation more difficult. Looking at the images, though, I do not see where I can make the diagnosis. The lateral rectus in that right eye is not way down the way it is with the heavy eye syndrome, and the superior, I think they're essentially in proper position. I don't know, and also you can see certainly in the right eye, in the upper right picture, the connective tissue band between the superior rectus and the lateral. Go to the upper right picture. You can see, I'm sorry, the other, I may be seeing it reversed. the one in the upper right of the screen.
Okay.
The band looks intact.
Okay.
So I do not see this as heavy eye. I don't think it matters whether you get CT or MRI. I mean, these images should be adequate for making that diagnosis. I worked with one of our neuroradiologists had a particular interest in orbital, strabismus and eye muscles, and we just had a standard protocol for looking at the orbits. But I think these images are adequate. So I think, like, as we said before, when an eye doesn't move, you have to decide if it's restricted or paretic. And you've done very generous medial rectus recessions, but let me just look. I just want to look at something here. But these still could be restricted. And I think if it's restricted, you're just going to have to put the medial rectus back further. And if it's not restricted, then you've got to decide. I have no personal experience with doing transpositions in thyroid eye disease affected muscles. But, you would, if it's not restricted, if it's paretic, you're going to have to do that. And again, we're left with, just superior rectus transposition. I'd probably lean toward just a superior rectus transposition because the inferior is so much more commonly a bad actor in thyroid eye disease. And I think I just wouldn't want to stir anything up with that. But you could probably get the patient somewhat better.
Okay,
Did you do more new MRI? No, I don't think you need special cuts, but I think the images you had are adequate. Repeat force section, re-reset. Yeah, that's the Yokoyama procedure. I haven't ever done that in a patient that I didn't think had the heavy eye syndrome. So, that's certainly a possibility.
Can I add a comment on this case?
Sure.
So, Sara, did you repeat the force duction test after disinserting the medial recti on both eyes? This is the first question. And did you notice any fundus intorsion in this patient? It's just that I'm thinking in one of the cuts, it has been reported that the superior oblique muscle might be affected by the thyroid eye disease, and it's a cause of the persistent esotropia in such patients, but you would have found an intorsion and a positive force duction test even after disinserting the medial recti. Would you consider this in this case? What do you think, Dr. Kushner?
I don't think, in my experience, it's not that common for the obliques to be involved with thyroid eye disease. But that said, I've seen it. It can happen. I don't think I can attribute this big an esotropia to involvement of the oblique muscle. I think it's always good to pay attention to torsion because that gives you an idea of what's going on. But
So there was no significant torsion on examination. There was no significant torsion.
No significant torsion.
Yes.
Can I add something also? Would you consider doing tests for myasthenia for this patient? You may sometimes have myasthenia with thyroid eye disease.
Yeah. So, that's also a good question because in a way, you could make the case you do that in all patients with Graves. Unless I saw evidence of variability, it wasn't presented as something that's variable. It was a big deviation and it was undercorrected. That doesn't make me think of myasthenia. I certainly wouldn't fault testing for it, but I'd be a little surprised if that's what the answer is.
I didn't perform test for myasthenia where the deviation was constant all the time. The patient didn't experience diplopia, so I didn't think of myasthenia. What we did, the second surgery was, sorry. We repeated the force reduction. I couldn't shift. I don't know what happened. We repeated the force reduction test was still tight, and we performed a re-recession of the medial rectus up to 8 millimeters. What we found intraoperative that the insertion of the medial rectus was a broad one. It was inserted over 2 or 3 millimeters. It has a very broad insertion, as if the anterior fibers were less recessed than the posterior fibers. And we performed a lateral rectus resection of 6 millimeters. This was the opinion of Professor Dr. Ahmed Awadein, and post-operatively the patient was properly aligned in the primary position with a marked improvement in abduction. I'm trying to shift the slides, but we'll try to share it one more time to show you the pictures post-operative. These are the photos of the patient. These are the final photos of the patient post-operative after re-recession of the right medial rectus 8 millimeters and performing a right lateral rectus resection of 6 millimeters. So I'm asking you, Dr. Kushner, again about your opinion regarding resection in thyroid patients. If it's unusual.
So I think that I in general tend to avoid it. I know that there are select cases where you can do it. I think you, in general, want to avoid doing it on a muscle that is affected by the thyroid eye disease. The lateral rectus is the least commonly affected muscle. So I think if you're going to be able to get away with doing it, you're probably most likely to do it on a lateral rectus. I have done it, and very, very infrequently. I was influenced early on in my career by seeing two really, really bad effects of resecting a thyroid muscle, where there was just a horrible inflammatory response that just never quieted down. But in muscles that don't have active disease and aren't that severely affected, like the lateral rectus often is that way, clearly people can get away with it. I tend to avoid it unless I feel I have no other options. If I have no other options, then I will do it.
You would have preferred to perform transposition after re-recession or here to avoid lateral rectus resection?
I avoid resections.
Thank you, Dr. Kushner.
Okay.
So what would you have done differently in this case, Dr. Kushner, rather than the lateral rectus resection?
You know, it's a hard question to answer without being there. You have to assess, what is the muscle, what does the medial look like, how tight is the medial rectus? I think that if I felt there was enough restriction of the medial to account for the deviation, it's a very subjective thing, I might just do the medial rectus recession. Now, obviously, that wouldn't have been the case here because got a good outcome and the medial was re-recessed plus a lateral resection. I probably would have done a transposition of the superior rectus. But let me back off on that. If the medial was tight enough that I felt I needed to do it, I don't think I would have done a transposition combined with having the medial 8 millimeters back. I think that that's asking for an overcorrection. So I probably would have resected the lateral in this case. Okay. It's a judgment call based on how tight it is.
Yeah, thank you. So Rasha, would you want to conclude this interesting, nice episode?
Yes, unfortunately, yes, it has come to an end. And Dr. Kushner, we would like to thank you very much for being with us today and for very useful insight on all the cases. We hope to see you again, hopefully next time in real person in Cairo. And we would like to thank all our audience, and we are so sorry for keeping you so late and for taking so much of your time.
It was fun. I appreciate it. Thank you. Have a good evening.
Thank you.
We'd like to thank all our speakers for such interesting cases. Thank you.